Welcome to today's eye review session. My name is Yejun, a second-year medical student at the University of Calgary. Our team will present to you today about branch retinal artery occlusion as a link between ophthalmology and cardiology. Branch retinal artery occlusion, or BRAO, is a blockade of a vascular flow in one or more branches of a retinal artery. This leads to focal retinal ischemia and usually results in severe visual losses. The BRAO involves the artery at the retina, so let's examine that layer. Retina is the innermost layer of the eye, the outermost being the sclera and the conjunctiva, and the middle layer being the uvea. Uvea is divided into anterior, iris, and the ciliary body, and the posterior, choroid layer. And if you face the retina, there are different parts according to the area that you look at. The more nasal part has the optic disc, and you can see that in the upper right picture there. And this optic disc is the collection of the ganglion axons exiting the retina to feed the brain of visual information. The optic disc is also known as the blind spot because any light that converges on that optic disc will not be translated into electric signals in the nervous system. On the other side, more temporally, you'll see the fovea and the macula. This is where the highest concentration of cones reside and therefore the highest visual acuity. When you look at an object via your central vision, this is where the light from that target will converge. And of course, the main topic of this presentation, you cannot ignore the vessels of the retina. If you look at the retina through a fundoscopy, you'll see all those veins also demonstrated in the picture there, and you'll be able to visualize both the veins and the arteries. Veins are usually wider. The retina itself is composed of multiple layers as well. There's the famous retinal nerve fiber layer, or the RNFL, the ganglion cells whose axons will converge into the optic nerve, the inner and outer plexiform layer, and the photoreceptors, of course, composed of the rods for low intensity light and cones for the higher ones, and the retinal pigment epithelium, Bruch's membrane, which acts as the border between retina and the choroid. Here is perhaps a more helpful illustration of the retinal anatomy and also the context in the eye by which the retina resides. If you look at picture A, there's the light first enters through the cornea and then the anterior chamber. Iris controls the size of the pupil and therefore the amount of light that comes through. The light will then pass through the lens, which can refract the light and also adjust the degree of refraction. And then the light will go through the vitreous body, and then converge hopefully on the retinal layer. And there's a cross section of the retinal layer as well. It's just the layers that I talked about in the previous slide, but in pictures. So circling back to the BRAO, the reason for the retinal artery occlusion we observed in the previous anatomy slide is because something's occluding it, and it usually comes from the systemic circulation. Elderly patients, especially in their 70s, are at special risk. The other risk factors include hypertension, because it can create turbulence, and also carotid occlusion, whether because the artery is naturally narrower or because the elasticity has been lost. Diabetes can create a blood with especially high viscosity, and therefore it can clog the internal carotid more easily. And also cardiac valvular disease can cause stenosis, and this causes abnormal turbulence as the blood exits the heart as well. I mentioned turbulence because the blood is full of coagulating factors, and unneeded excess movement of the blood can cause undue clotting process. But the BRAO can be caused by other processes as well. More famous causes are the Hollenhorst plaques. If the patient has an abnormally high amount of cholesterol in their blood and has also been hospitalized for something like arteriosclerosis, then it is likely that the cholesterol can form embolism within some of the blood vessels. This happens because blood is a continuously flowing mechanism, and when the cholesterol deposits on the vascular walls and they build up, eventually some of the blood flow is going to take little chunks of cholesterol along with them. These are called the Hollenhorst plaques. Because they're so small, it can infiltrate to more deeper capillary networks all around the peripheral vasculature. It can invade the brain, and in this case, enter the retinal artery and block and cause BRAO. Calcification is also possible because of the heart valvular disease, and platelet fibrin plugs from arteriosclerosis is also a possible etiology. Here are more rare etiology of BRAO. If we have Pursh's retinopathy, the emboli can be created from the coagulation of leukocytes, because there are higher levels than normal of the white blood cells in the bloodstream. Fractures of the long bones can break the marrow and release lots of fat into the bloodstream, therefore causing a fat emboli. Myxoma or heart cancer can release the tumor cells into the blood, and they themselves will form little chunks of emboli. If the IV drugs are used, or if there's a bacterial endocarditis, septic emboli can form from the clumping of bacteria within the blood. Giant cell arteritis as a cause of anterior arteritic ischemic optic neuropathy can be a cause of BRAO, as well as other inflammatory diseases like dermatomyositis, lupus, polyarteritis nodosa, and vasculitis. Other systemic causes include migraines, compressions due to mass in the anterior part of the head, as well as coagulopathies, abnormal tendency for the blood to coagulate and form clots. These can cause BRAO. When the patient comes in with these symptoms, we should be suspicious of BRAO, and these are sudden and profound altitudinal or sectoral visual field loss, and some of that's demonstrated in the picture here. The characteristic is that it is painless. It doesn't hurt. It's unilateral usually, because clots enter just one of the eyes, unless it's due to a systemic illness. And if they've in the past also had a history of temporary vision loss or stroke or TIA, we should be cautious and rule out BRAO. And when we observe the eye, we might be able to see a focal area of retinal whitening, usually on the temporal other side of the optic disc. And this is because of pallor caused by not enough blood flow to that area. The similar observation can also be made in commotio retinae, where the retina is bruised due to external forces. And sometimes we might be able to see Hollenhorst plaques within the artery that's causing the BRAO. When tested with the Humphrey chart, the patient will have a visual field defect. In this first eyepiece, we've discussed epidemiology, etiology, the definitions, and the symptoms and signs of BRAO. In the next eyepiece, we will discuss the investigations and treatment for BRAO.